I'm Jack Ratouche, and this is Best Practice Guidelines Part 4, Facial Nerve Monitoring. Are you using insulated recording electrodes? If so, you may be increasing your chance of false negative errors. Let's take a look at the details. There are two types of monitoring electrodes in facial nerve surgery, stimulating and recording. Both conduct electricity, but there are distinct functions. Stimulating probes transmit current. They can be mono or bipolar, and some degree of insulation is necessary. Recording needles record the muscle action potential. They've always been close bipolar pairs of non-insulated needles, and only the cabling is insulated to reduce electromagnetic interference. Now, let's do a deeper dive just on the recording electrodes. As noted, close bipolar pairs of non-insulated needles have been the standard for many years, and the montage itself has changed little over the decades. However, to adapt from 2 to 4 channel monitoring, we now add mentalis to channel 3 and either trapezius or masseter to channel 4. The details of this new best practice can be seen in video part 3. So, summing up ideal characteristics of recording needles, while the cable should be insulated, and if there is a pair they should be twisted to reduce artifact, the needle itself should not be insulated because it acts as an efficient antenna to detect the EMG signal. The needle needs to be long enough to contact the target muscle. Well, if for decades the standard has been non-insulated needles, why have some begun using insulation? As it turns out, there was some justification, but is it still valid? We know that insulating the recording needle has 3 downsides. It reduces the electrode muscle contact, thereby reducing sensitivity to detect small potentials. It also reduces accuracy of the needle placement, and it increases impedance. Individually and combined, all of these increase the chance of false negative errors, some of the worst errors you can possibly have in facial nerve monitoring. Let's look at each of these 3 downsides individually. By reducing sensitivity to detect small potentials, we increase false negative errors because the exposed needle is your antenna. The more you cloak it, the more you compromise recording. On the left, we can see an insulated needle. On the right, we can see non-insulated. Now let's talk about the accuracy of EMG needle placement. It turns out it is surprisingly poor even in the large leg and arm muscles. And with facial muscles often being less than 2 millimeters thick, you can see the accuracy is exceedingly poor even under the best facial monitoring conditions. Therefore, we cannot afford to insulate needle electrodes, which only exacerbates the underlying issue. Looking carefully at the illustration on the left, we see the black insulation with only a small amount of non-insulated area at the tip. The needle has gone slightly through the muscle, and therefore at no area is the needle electrode actually in contact with the muscle, a complete miss. In contrast, the illustration on the right shows the red uninsulated electrode, and even though the position is identical going through the muscle, because the sheath is bare, it does remain in contact with the muscle. And finally, our third intrinsic negative to insulated electrodes is that they markedly increase resistance. A typical bare needle electrode has an impedance of less than 5 kiloohms. However, insulated electrodes, such as the brass pair needle, may have impedances as high as 25,000 kiloohms, in other words, 5 times higher. There is yet another negative ramification of high impedance. Most monitoring devices perform an impedance status check on boot up. Less than 5 kiloohms has been standard to declare the test a pass, but insulated electrodes will all fail this norm. Consequently, Manufacturers who recommend insulation must change the standard 5K rule and instead use 25K. Thus, previously unacceptable impedance levels are now considered a pass. Is this really what we want? Ironically, devices with the most sophisticated artifact suppression are at the highest risk for missing small responses. This is proven by suppression of the tap test. Why? Because there is a synergy. Strong artifact suppression plus insulation of the needle may be powerful enough to suppress not only noise, but the actual EMG signal that we're looking for. So after reviewing all the negatives, are insulated electrodes ever justified? Well, yes, under two circumstances. The most common is performing EMG deep within the body. So if you are trying to find a deep arm muscle and pass the superficial muscles, having the proximal insulation and the distal bare tip is exactly what you want. However, this consideration has no value in facial nerve monitoring due to the extremely thin and superficial muscles of the face. Finally, we come to reason number 2, which was supposed to be a one-off, and that is COVID 2020. At the time, non-insulated electrodes became scarce due to supply chain issues. So insulated electrodes were sold as a temporary stopgap alternative. Unfortunately, no comparative testing was done, but impedance testing immediately showed that resistance was much higher, as we've already indicated. Unfortunately, the coup de grace, rather than be removed after COVID, they inadvertently became recommended as a standard recording electrode, as can be seen in some of these manuals. So now let's take our lessons learned and apply it to best practice guidelines and checklists. As we've talked about before, one of the first things that needs to be done is a tap test and a check of impedance. Therefore, failure to elicit a tap test should be a warning. Have you used insulated electrodes? Is there improper setup? Is there a device problem because of too much artifact suppression? Is there neuromuscular blockade? You can see that in 2023, the NIM Vital had actually warned against a tap test. It is my understanding that this guide will be changed for the future, indicating that with proper electrodes, the tap test will indeed function as it always has. And I would be remiss without reminding you again that in addition to the tap test, you should always perform transcutaneous stimulation before the incision. By stimulating through the skin, you'll prove recording is proper, stimulation is proper, and that there is no neuromuscular blockade. In summary, we have provided detailed documentation that insulation of recording needles should be avoided to prevent false negative errors. Check your stock, check your suppliers. If it's insulated recording electrodes, just say no. Coming up will be the grand finale of my 5-part video presentation, this one on stimulating probes and active nerve monitoring. TLDR, why in 1977 I designed the nerve monitor the way it was, and why you're probably still using it wrong after all these years.